Okay, hello everyone. I'm discussing now for the fourth ticket to class fluid and electrolyte actual medications. And most of them you'll see are a little bit different than a lot of the medication groups we've already talked about. The first one I'm going to talk about are basically IV fluids, and these are referred to as crystalloids. They supply water and sodium to maintain that osmotic gradient between our compartments for extravascular and intravascular. They contain fluid and electrolytes that are normally found in the blood. So they're not really, they're more maintaining, they're maintenance type drugs. And here it is, most commonly used to maintain fluids, to compensate for insensible fluid losses, such as if we're draining out something through an NG, something like any tube that's draining fluids out. And there it is, to replace fluids when there are body fluid deficits, to manage specific fluid and electrolyte disturbances, to promote urinary flow. So we're going to give them extra fluid so we can bulk up that kidney and release fluid through the kidney. Much less expensive than our colloids that we're going to talk about in a minute, and blood products. No risk for viral transmission or anaphylaxis because it's just, again, an maintenance. There's specific fluids that are supposed to maintain our homeostasis in the body, not like blood products or colloids that actually have medications in them. And no alteration in the coagulation profile associated with their use, meaning they're not going to diminish our platelets or anything like that. A lot of some basic types of colloids or crystalloids, are normal saline, referred to sometimes as capital N as in Nancy, capital S as in saline, hypertonic saline, lactated ringers. You see that hanging all over the hospital. D5 and W, it's got 5% dextrose, so we have to be careful with this one as we see our diabetic population climbing. Dextrose is a sugar. And then our plasmolites. Contraindications to any of these, because we're adding extra fluid, is if the patient is hypervolemic. So they already have too much fluid in their blood. So they would be contraindicated for the crystalloids. Okay, now let's talk about the colloids. And these are different in the crystalloids in that they're much denser. They have protein substances that increase our oncotic pressure. Normal is about 24 mm per Hg, and effectively move fluid from the interstitial compartment to the blood compartment by pulling fluid into the blood vessels. So again, it's going to increase oncotic pressure by pulling fluid into blood vessels. Types of colloids would be dextran, albumin, hetastarch. Albumin is probably the most frequently that we see, 5 to 25%, and that would be the dose. Must be administered very carefully because there is a risk of congestive heart failure and hypervolemia. Why? Because it's much thicker volume, much thicker. And again, contraindications for any of those would be if the patient is hypervolemic. And then finally, we have our blood products. They can be thought of as biological drugs, the only class of fluids that are able to carry oxygen because they contain hemoglobin in the blood. Our red blood cells can also improve tissue oxygenation as well as augment plasma volume. Most expensive, these are very, very expensive, all the blood products, and least available than crystalloids or colloids because they're natural products and they require human donors. And that all makes sense. I don't need to explain that to you. FFP is known as fresh frozen plasma. This increases clotting factor levels in patients with a demonstrated need. They are thrombocytopenic for whatever reason, if it's hemorrhage, accident, chemotherapy, so forth and so on. And then packed red blood cells increase oxygen carrying capacity in patients with anemia, profound anemia, patients with substantial hemoglobin deficits, and patients who have lost up to 25% of their total blood volume, such as an accident with a hemorrhage or postpartum hemorrhage. Usually we can stop that before it's 25% with the postpartum folks. And they will also give packed red blood cells if they had a lot of chemotherapy and they basically can't move because they're depleted. with hemoglobin in their body from the chemotherapeutics destroying the red cells. And then whole blood is very similar to packed red blood cells, except that whole blood is more beneficial in cases of extreme blood volume loss, since whole blood also contains plasma, which is the chief volume of the blood. It also contains plasma proteins found in the plasma, the chief osmotic component, which helps draw fluid back into blood vessels from surrounding tissues. So that's the difference. Where packed red blood cells are just red cells with a lot of hemoglobin in them, whole blood has packed red blood cells and plasma in it. And that's it. Can you believe it? For your ticket to class, I believe this is number 4, fluid and electrolytes. Basically, we're talking more about fluids, and then we can add electrolytes as needed, which we will talk in depth about electrolytes and how they affect different body systems and major organs and communication with cells in the body. Okay, I hope you're having a great day. Talk to you soon. Bye-bye.